Thank you so much for joining us today. I'm Yuping Chang, the Associate Dean for Research and Academic Affairs here at the School of Nursing. And we are so excited to welcome you all back to our first in-person annual Research Day and Bonnie Bullough lecture since 2019. Our today event will begin with a keynote presentation, followed by a poster presentation, and we will conclude today's event with a poster awards ceremony. A lunch will be available after the ceremony, so make sure you grab a lunch box on your way out. Today's event has 47 posters during the poster presentations from our students, faculty, and community partners, including the ECMC and the VA. Our community partner, I'm sure, is somewhere in the audience. So thank you so much for joining us today. So now I would like to welcome our Dean Annette Wasaki, to deliver her welcome message and introduce our keynote speaker. This is Dr. Wasaki's first annual research day here with us. So welcome, Dr. Wasaki.
Thank you. It's such a pleasure to see so many people from our community gathered here with us today. And I can't be more delighted than to be able to be here to join you for this special event. So as Yuping said, this is actually my first time to attend this event. So I'm looking forward to really taking the opportunity to look at all of the wonderful posters from everyone. And I know I've been attending some of the dissemination events, and we did one actually yesterday for one of our CRNA students, which was really quite impressive, looking at ECMO and its use and anesthetic agents. So I know that was something that I've really enjoyed learning about, the quality of the work that's being done by our students and faculty here in the School of Nursing. So again, it's my pleasure to welcome you here today, and also my great pleasure to introduce you to Dr. Kavita Radhakrishnan, who's an associate professor at the University of Texas at Austin School of Nursing, for our 26th annual Bonnie Bullough lecture. Dr. Radhakrishnan's research applies current and emerging technologies such as telemonitoring, connected sensors, and digital gaming to facilitate chronic disease management. And the long-term goal of her research has been to develop affordable and scalable health interventions that enable aging in place. Her research project studying digital games for and all of the work that she's been doing has garnered over $6.5 million from the National Heart and Lung and Blood Institute and the National Institute of Nursing Research at NIH. I have problems. I don't need my glasses to read, but I need my glasses to see you. So she is, again, currently as being a PI on these two randomized controlled trials that will be examining digital gaming and connected health sensors to enable self-management behaviors for cardiovascular disease. And again, we know that congestive heart failure and other cardiovascular disease are still the number one cause of mortality in the United States. So she's been looking at these in a couple of different communities, but also in a way to address health disparities, as well as looking at hypertension and outcomes among Native Americans. And as I found out last night at dinner, I'm originally from North Carolina, and one of her studies she's working on is with the Lumbee Nation in North Carolina. So, and actually not far from where I have some connections as well. She's authored more than 50 articles on the subject, which has been cited in publications in more than 30 countries. She served as an expert advisor on the American Heart Association Policy Task Force on implementation of telehealth in cardiovascular and stroke care. And she's a member of the American Heart Association Cardiovascular and Stroke Nursing Committee. Dr. Radhakrishnan received her BE degree in electronics engineering from the University of Mumbai, her master's degree in electrical engineering from the University of Texas at Arlington, and her bachelor's and PhD degrees in nursing from the University of Massachusetts Amherst, which is actually how I first came to know about Kavita. She served as an ad hoc reviewer on the clinical informatics and digital health and biobehavioral medicine and health outcomes study sections for the NIH, And as we found out last night at dinner, she's currently on the standing study section. So that's a big responsibility. She's also serves on the expert panel on informatics and technology of the American Academy of Nursing, where she's a fellow. And then she's also a member of the Texas Department of Health and Human Services, Texas Cardiovascular Disease and Stroke Partnership. So again, it's my great honor to welcome Dr. Radhakrishnan to join us for her presentation today.
Thank you, Dean Vaisakhi, for that excellent, rich introduction. And thank you all so much for having me here. It's a real pleasure to be here and to talk about my work about sensor control digital game, which is a mouthful, but it's an intervention, a platform that my team has developed for heart failure self-management. And then we started off with heart failure and now applying to other chronic diseases, other cardiovascular diseases, and other populations. These findings are reported here or just based on research, even though they were funded by NIH. It's solely the responsibility of ours and does not necessarily represent the official views of the NIH. So just to give a context about heart failure, we know that heart failure is a costly disease. It's on the rise. It's a leading cause of hospitalizations, especially among older adults. And with COVID, the sad thing is the effects of long COVID or just COVID, the odds of now being diagnosed with heart failure is even higher than before. So this is a big problem. So as nurses, and I believe it's my philosophy that self-management is one of the key treatment strategy to help keep the quality of life of people diagnosed with heart failure intact. I used to be a home health nurse, and I started off in the ICU, and then I moved on to the med surg, and then I became a home health nurse. And at every point, it became critical that the only way to keep people safe at home was to equip them, empower them with self-management skills. So that's why I believe that self-management is a very critical treatment and management strategy to keep people at home, which kind of aligns with our philosophy of aging in place. But that's easier said than done, right? It's really hard, especially with heart failure self-management. There is so many things to do. There is a life routine. How do you integrate all these different activities within your life, and especially when a lot of older adults especially are not used to making these changes in their life. So and research has shown that low adherence to self-management often results in high healthcare burden and suffering. So that kind of informed me. And again, with my experiences as a home health nurse with telemonitoring and telehealth, one of the big gap that we saw is there tools like telehealth was a great start, but it wasn't providing a context to the disease. It wasn't providing a context to the metrics that were being collected by telehealth. So, which is kind of informed of a unique and promising approach of this sensor control digital game. So how can games help? Well, one of the key issues that, and especially because I come from Texas, right, where institutions are like miles apart, like hundreds of miles apart. And how can older adults safely travel, especially if they're frail, to multiple provider appointments when the institutions or healthcare institutions are so far apart? So an intervention, like a technological intervention like digital games, can help these avoid frail patients, help them avoid travel and bridge that gap between healthcare provider appointments. So many times I have clinicians tell me, we meet them once in 3 or 6 months. What happens in between is out of our control. So what can we do to help keep that same consistency in messaging in the time that between the provider appointments? So that is another gap that digital games can help. Mostly it's like an accessible and habit forming medium. What I mean by that is it's not intimidating, right? The moment I say the word game, it just seems cute, it seems fun, it's not intimidating. And a lot of the times older adults need that kind of like, I'm not going to take this seriously, and maybe like disarming, the anxiety for probably fostering like more learning. And then most importantly, especially post-COVID, we have a crazy provider shortage now. There are just not enough providers to go around. Like, how do we alleviate that provider shortage? It's not like these technologies is not going to supplement or take over providers completely, but we need something right now to kind of complement providers. And that's the role that I see digital games playing. So why digital games? So when I first started off on this line of research in 2013, 2014, there was a major pushback, right? That older adults, technology, digital games, they don't go well together. But the truth is there has been an increase in digital or older adult digital game players, 52 million senior game players in 2022. This has been a 12 million rise from 2016. And what is shocking, I keep updating these slide for every year, for the presentation. I look at few statistics and the numbers are mind-boggling. And so the last one I had was somewhere in 70s, and now it's like 84% play on smartphones and their tablets. So that's just an increase. And again, one thing that COVID did is that people had to ramp up to technology sooner than later. So because, we all know that they had to be on Zoom to keep in touch with their church members, even practice choir, be in touch with grandchildren. So that's kind of what happened. And then I already mentioned that it can be accessible, right? It can be easy to use. A well-designed game can be really easy. It's as simple as like clicking a button. And we can, with enough usability techniques, we can make a medium user senior friendly, what we call. The fact is, digital games are everywhere. It is ubiquitous, and the flexibility of the medium means it can be played on anything, right? Tablets, phones, computers. It can be engaging. Again, a well-designed game can, especially when you had competitive elements, then it can be really engaging and entertaining. Disease self-management. And who says disease self-management has to be boring, right? Even the word is like, ooh, it's a mouthful, but it doesn't have to be boring. So why not bring in some entertainment? And there are tremendous potential for personalization. I think too often we complain that our healthcare interventions don't seem to work because it's one size fits all. It doesn't really cater to the different needs of different people. But with the games, you have that kind of flexibility to create different triggers for different motivations, different motivational messages, like what might appeal to one. Some older adults may like competitive games, and some older adults may like cooperative games. So it's easy to make that kind of personalization, and also the kind of incentives. And I'm going to talk about different kind of incentives that we attempted in our game. Disclaimer, those are not the only ones, and anyone can be creative to think of any kind of incentives. So when we talk about games, we talk about, and I'm sure you all know the term gamification. It's being used a lot these days. So some kind of framework, kind of elements that you see when you have an intervention like games. So some of them are like points. So points are like the kind of incentive rewards. It's kind of like you have a reward center in the brain, and every ping you get, the reward center gets satisfied. So that's a kind of points. Badges or something that you aspire for that can motivate long-term quests. So you can aspire for long-term behaviors. And then leaderboards are critical for fostering competition. It was very interesting in my study that I have seen an 80-year-old woman who was really motivated to remove the person who was number one on the leaderboard. She was like, I am doing whatever I can to be number one. I want to beat that person who is number one on the leaderboard. So it was really interesting to see the role that leaderboards can play in motivating that kind of behaviors. And then finally, rewards, right? And the rewards can be anything. In our For example, in my study, so the thing with heart failure is you need to have a low salt diet, low sodium diet. And in our preliminary studies, they voiced that for the most part, they're doing okay, but it's at 3 p.m. snack craving where they lose it. So they said it will really help us if we can have recipes for that snacks, that low sodium snack craving around 3 p.m. So we designed that as an incentive in one of our games. So, my point is like, can be anything. So I'm going to talk about my digital game research trajectory, which I know we have a lot of young faculty, junior faculty, students, graduate students in the audience. So I wanted to say that it looks daunting now, but, it had to start somewhere, and it always starts really small. So my first study was as a junior faculty. I got funded by a P30 funded grant. It was a pilot project to get funded by the P30. And then the results from that study informed the R21 study, which was about close to $500,000. But I want to say there was a gap between the P30 and R21. I got funded with the P30 in 2014. It took me 2018 to get funded with the R21. So it was a slog. It took me 3-4 attempts before we finally got the next grant. So patience, perseverance matters. And then the R21 findings were encouraging enough that we got funded by one R01 and backed by another R01, which was surprising. And then obviously we're going to use all our results from our R01 to inform more studies. So I just wanted to show this, that it had to start somewhere. So I'm going to talk about my first project. So this was, like I said, the pilot study, and we use a casual digital game for heart failure self-care, a really small study, and a funding amount was about $40,000. So this obviously means we didn't have a lot of money to put in games development, given that we also had to conduct a study with older adults. So it was a strategic decision how to make this amount go far. Okay. All right. Oops. There. So when I say casual game, I know this is super stereotypical of older adults, but this was a pilot study. So we used a casino slot game and to trial out the idea, do older adults even like playing games for health? Does that concept even appeal? So we decided to try it out with a casino slot game. So what we use, and we use this a lot in our studies, we use this concept called off the shelf. What that means is like this game was already developed and we just kind of borrowed it. They were kind enough to let us borrow the game. And in the place where traditionally advertisements or other banners would appear, we would insert our content. And the game medium, something to remember is that what we call the real estate is really low, which means any information that you have to provide has to be in bite-sized chunks. The good thing with bite-sized chunks, it's more digestible. And it's not just about food, it's also about information content. So we had to really break it up so that it's more digestible. So that's something the game medium forced us to do. And what was the incentive? So the idea is the players have to engage with the content and then answer the quizzes. And only if they get the quizzes correct do they earn the coins or the slots to play in the casino slot game. So if they want to play the casino slot game, they have to engage with the content. So that was kind of like the basic idea of trying out different game elements and I believe we were one of the first people to try this idea of using games for older adults for a chronic disease like heart failure. So we were pleasantly surprised that even though we tested it out with 19 people and it was a pre-test, post-test, one group, and even though the participants had heart failure for more than 10 years, we were pleasantly surprised to see that knowledge actually increased. So when we talked to our participants, they said that, they often get these papers from their providers and that intimidated them. But in the game medium, for the first time, they were actually engaging with the content. I mean, some of them didn't even know how to read a nutrition label and how to identify sodium or high sodium or low sodium food items. And now they were finally able to do it with this game medium. So that was really heartening to see. We also found nearly 50% of our participants were educated at the high school level or lower. And so it was really good to see that knowledge increase, especially in that age group. So, like I said, we had techniques, elements like mastery learning, such as mini quizzes. So there was a way of engaging with the content. Now, all of this is cool. And I also wanted to say we have this study published in this article. But all that is nice, right? I mean, we all know, and especially as nurses, knowledge improves is good, but does that really mean behaviors change? So what happened in that first study is we demonstrated that knowledge improves. And, in one of the conferences I went, one of the students even asked, what's the point of a game where they're just sitting on their, they're behind and playing the game, but what does that even do to the self-care? And that's a great question. So that's what informed our next study, which is the sensor control digital game, which is and that was a second study. And I'm going to talk about what does that mean. I don't know why I keep, there. So this study has implications for precision health. We often hear precision medicine, precision health. So the idea is sensors, right? I mean, there are just so many advances happening in sensors these days. We practically have sensors collecting metrics on any part of the body, even wound healing. So it's really fascinating time for sensors. So what this game does, it can take the data from the sensors and you can input it into the game to direct game progress. So the idea is the player can only do well on the game if they're doing their behaviors that is being tracked by these sensors. So this has a lot of implications for precision health, because remember I said context. What is the context? We need the context to health information. So I had participants who were, I had patients who used telehealth and they used to get the vital signs, they used to get their weight, but those were just numbers. It meant nothing to them. How do you provide context? And that's by pairing their behavior data and the sensor data in a game medium, it kind of helps provide that context, what does that health information mean to their behaviors. And the idea is, like I said, the game progresses, the story progresses with personalized behavioral feedback. So based on what they do, they get the behavioral feedback. So it's literally tailored to each person's behavior. And then, like I mentioned, there are a lot of creative game-based incentives. There's a lot of creativity possible there. All of this tied to their real-time behaviors. If they don't do their behaviors in real life, they're not going to get the incentive. So the whole idea is behaviors, what do you do to change behaviors? And the idea is they play games long enough that I know we have heard about Pokemon Go. I mean, I almost anticipate this question. Pokemon Go was so popular. A lot of these games were a fad, but they were just fads, and people stopped playing games. I used to play Candy Crush for the longest time, but I don't play it anymore. So what? But my pushback, my argument to that is we don't want them to play the games forever, but just enough for them to generate habits of those behaviors. So even if they're not playing those behaviors, the behaviors stick. It's easier said than done. Human behavior is a holy grail and tough nut to crack. We accept that. But whatever we can do to have progression, progress in those behaviors can help. And this is one platform that can help doing that. So I also wanted to kind of introduce the idea of design thinking. I wanted to kind of mention that this is never end. It never stops. There's constant iteration. We are constantly going back, changing our design, changing our prototype. It's a constant loop of feed forward and feedback loop to go back. We go back to the drawing board. So in our first study, we empathize is that we always conduct some kind of qualitative interviews. Qualitative interviews are often the bedrock, the foundation for our designs, because then it's authentic, right? It's grounded in reality. So, and plus, aligned with my own experience as a clinical clinician, we feel like we're able to bring that authenticity in our designs. So we started off with qualitative interviews with older adults with heart failure on what they would like to see in a medium like that. And then we went and defined it. And of course, we never had the money initially, right? So we developed mock prototypes. And mock prototypes are as simple as PowerPoint slides, just to demonstrate our idea. Look, if this is how it looks. And there are other ways of mock prototypes. I'm sure you can work with some industrial engineers or UI UX engineers, and they do some mock prototypes. So you can go back and show, okay, these are our ideas. What do you think about that? And then we get some more feedback. And then we got the money, we built the initial prototype, went back, tested it, got more feedback. And then when we got more money, then we used that to make more adjustments. Does that mean we are done? Not really. And now with the feedback that we are getting in our current study, we will go back and make more adjustments. So we are always constantly iterating. So this is kind of the trajectory for developing an intervention like this. Is like I mentioned, first we start with the qualitative interviews using mock prototypes. We develop the prototype. Then we conduct usability assessment. Before we actually test, we, especially because we are, a lot of the technology is conducted labs and is conducted with young people who are already technologically savvy. But we aspire for what we call in the wild testing with our actual target audience who are older adults. And how does it work in their homes, right? Like how is Wi-Fi? What are the technological constraints that happens in an actual home setting? And these are folks who are, on Medicare and fixed income. How does our technology scale up in conditions such as that? So we conducted a usability assessment, and then we found some gaps, went back, modified our prototype, and then we did our first pilot feasibility trial. So that's pretty much our trajectory. So finally, this is what I'm talking about. This is our first attempt at that sensor controlled digital game. The idea is to climb a mountain. And why a mountain and why a forest? Again, it came from our participants because a lot of them said, ever since I've had heart failure, I miss nature. I haven't been able to go out and walk on a trail or go to forest, go camping. So kind of used that to inform our idea. And we put in bird sounds and they loved it, like the background of the game as bird sounds. So here we are, we have an avatar who climbs the mountain, and they can only climb the mountain if they do their behaviors, which in heart failure, we operationalized as weight monitoring. Daily weight monitoring is a very critical behavior for heart failure. And then activity tracker, because I believe physical activity, again, even if they start off with 5 minutes and then increase it to 10 minutes, it is critical. So we were using those two behaviors for which we can get the metrics to feed into our game. And that's what, the avatar does. And then they get this feedback if depending on how they did the behaviors, whether they did it correctly, whether they did the goals, whether they attained their goals or not, the feedback would be a positive message. And then we have the stars here. So the stars are like kind of give them the daily quests, like what are the daily quests that they need to attain. And so they are able to get that context that multiple behaviors needed to be done at the same time. So, these are just some visualization techniques that we were using to in this game for motivating behaviors. Some other things that we use, so it's not just about behaviors. Of course, we were also using this as a medium to impart information, content. we think like games are a safe medium, right, to test out reality-based decision-making scenarios. The kind of scenarios would be if you're in a grocery shop and you have 2 items for a certain recipe, which one would you choose? So we were bringing all of those things in our game. And then the other thing is there are other kind of behaviors that they can safely attempt, that they can repeatedly attempt those behaviors. Even if they make wrong choices, it's okay. It's a safe medium. But this is a safe medium where they can practice those skills so they can transfer and apply it in real life. So again, this is an information about some pictorial, lots of pictures, lots of bite-sized chunks, and lots of this is a material that we got from NHLBI. So sometimes we use a lot of off the shelf. We don't like reinventing the wheel because there's a lot already available. And so we use a lot of what's already available with, of course, due attribution and due copyright acknowledgement. And also a lot of the times the articles or materials developed by NIH is like free to use and accessible. And this is an example of how to recognize low sodium. And then the other thing is visual responses, right? Like pictures speak 1,000 words. So then we make changes in the avatar. So in heart failure, the thing to be scared of is if you're bloating, right? Because your body fills up with water if your body is going in crisis. And that could be based on behaviors. So a lack of healthy behaviors would be seen in this unhappy, bloated looking avatar, but a healthy behaviors would be in this happy, fit-looking avatar. So that is how we were visualizing even changes in the avatar to demonstrate their progress in behaviors. So quickly, I'm going to talk about, so pre-COVID, it was different days. So pre-COVID, we were doing the conventional. We had partnership with our clinical partners in Austin. I'm from Austin, Texas. And we partnered with our clinical partners, and we got our participants from a cardiac rehabilitation floor and from the cardiac floor. So our eligibility criteria were 55 years or older with a heart failure diagnosis. Because this was a pilot study and we wanted to control some of the factors, for the pilot study, we wanted them to own a smartphone. But the subsequent studies, that wasn't a criteria. Like we were providing study smartphones. But just for the pilot one, we had that criteria. And then some exclusion criteria, such as no end-stage renal disease. So we were restricting it to people in the earliest stages, because when somebody is in a really advanced heart failure stage, the kind of self-management at that level is different. So we were focusing on the ones from 1st to 3 stages. So the study aims for the R21 was first to assess perceptions on this medium, sensor-controlled digital game medium. And then we wanted to see improvement. To test improvement was a randomized control trial, 2 groups. One group got the game and the sensors. The control group got only the sensors. So the idea is they're all getting the sensors, but just that one group gets the game. Why we were using it? Again, the same idea, right? Like Pokemon Go. A lot of us use Apple Watch, Fitbit. How many of us are really sticking with it throughout, right? So what is it that can make one stick with the activity tracker longer? So this is kind of testing that, but especially in a vulnerable chronic disease population such as heart failure. So we were testing definitely the heart failure self-management behaviors of daily physical activity and weight monitoring, along with other attributes such as knowledge, their functional status, quality of life, and hospitalization rates. But then COVID happened. So just as we were in the middle of the study, COVID happened, and then we had to completely revamp our strategies. At the beginning, to be honest, I thought that's it. My career is over. And I just fact everything, like what can you do? But, as researchers, we never give up, and something always goes on in the back of your mind, ticking. And so we decided we are going to do it remote. And then we used online recruiting medium, so social media recruiting medium. We partnered with a company. We had some money, advertisement money. So we partnered with them. We developed short YouTube videos for installation. So earlier, my GRAs, my research assistants would install the apps and devices on their phone. But now with COVID, and also given that heart failure were the most vulnerable of them all in COVID, we could not go near them. So then we just completely converted our protocols to a completely remote protocol. And then we used Zoom, FaceTime conference during installation. I know I'll get the question but were older adults able to do it? And I would say, yes, we had 90-year-olds and 85-year-olds. It took time. It just required some patience from our end, but we were willing to do that. And we were able to get people with their family support onboarded on our devices. And then we could do remote troubleshooting. And we always had online survey collection, because one thing we realized is that the best way to get the surveys completed is either through email, sending them through email, or sending them through text. And I understand not all older adults would fall in that bracket, but we were definitely seeing a higher response rate. And then we were getting the daily behavior data but tracked anyway. And I'm going to show what system we used to get that daily behavior data. So what happened is this revealed potential for scalability. So initially we were aiming just for people in Texas, but then we thought, well, if you're mailing the devices to them, and if it is, completely remote, why not just go all over Texas? So that's what we did. We went all over Texas. And then we also started getting people from Oklahoma. So then that really showed us that this, a huge potential for scalability. And we were getting people from cities or towns that were 100 miles from the closest city. So that kind of demonstrated that maybe in some ways, if our technology or platform was not accessible, in other ways it was, because we were now getting people who traditionally would not participate in clinical trials. So these are just some results from our pilot study. And remember, pilot feasibility studies are small. They're never meant to demonstrate statistical significance, but they're only meant to demonstrate the feasibility, implementation, and feasibility of implementation and encouraging trends. So that's what we did. So in our pilot feasibility study, we had 53% female, which was great because females tend to be underrepresented in cardiovascular diseases. And then 72% white and 41% had kind of newly diagnosed with heart failure. What was amazing to see is that 85% had played digital games before. This was a big difference from my 2014 study, where only 47% had played digital games before. This was a fairly educated cohort. 22% were high school education or lower. So the kind of trends we saw was in the game group, which you see in blue. We saw their weight monitoring for at least 5 days a week increased from 40% at baseline to 80% at 12 weeks. And then for the control group, it actually went down by 7 points. And then in terms of hospitalization rates, really, this was an artifact. You can't even consider the results because of COVID. And as we know, globally during COVID, cardiac hospitalization rates nosedived. Nobody knows why. Maybe people just avoided going to the hospital and all that, but that impacted, and we were obviously seeing that in our study. But let's look at step counts. So, because we had all this daily data, I know that's a really busy slide, but if you can just see the really dark black line and the dark red line in the center, you can see that the control group had a higher step count at baseline than the intervention group. But around 20 days, they crossed. And towards the end, there was a trend of a higher step count in the intervention group versus the control group. And over here, the joint behaviors, remember I said that star, and that gave them the visualization, they had to do multiple behaviors at the same time. And we could clearly see that there was a much higher correlation between joint behaviors in the intervention group versus control group. Like there was really no correlation between weight monitoring and step count. What it goes to show is that we could convey the, remember I said self-management is hard. You have to incorporate multiple behaviors in daily life. And this game-based medium demonstrated the possibility to convey the message that it's possible to engage in multiple behaviors. The whole idea is it provided a context to help behaviors. And that's what we were seeing in comparison between intervention group and control group. We also got some qualitative feedback. It was positive, mostly positive. Sometimes they didn't like it. There was some discrepancy between the withing step counts, and sometimes they have their Apple Watch. But really, it doesn't matter, because what we care is that from the baseline till the end, is there a change? And that's what we want to see. And sometimes they got annoyed because it ended so soon, because for them it was motivational for them to continue to pay attention to my heart failure regimen until it became more of a routine. Trust me, I did not pay this participant to say this, but this is exactly what we are aiming for. It becomes more of a routine that we wanted to engender with our games. So obviously, pilot study, I know $500,000 seems like a lot of money, but it isn't. It just goes off like that for a 2-year study. So we had just enough to build a game that lasted for 12 weeks, 3 levels. So it was a kind of a limited game, but enough to demonstrate our sensor-controlled, digital game concept. So I just wanted to point out, the studies, the results from the study got published in these journals. So then, because we got such encouraging finds in our pilot study, we immediately got an R01. And then in this case, because we demonstrated the feasibility of scalability, we now aimed at the states with the highest disparities in heart failure, which happens to be the southern United States. So we now have 7 states in our study: Texas, Oklahoma, Arkansas, Mississippi, Georgia, Alabama, and Oklahoma. So we have all these 7 states in our study that we are getting 200 participants from. So our study aims are very similar to the pilot, because the pilot was, like I said, it demonstrates the feasibility of implementation. So the R01 is relatively easier because we did the hard work in the pilot. So it's a kind of continuation of that, comparing the intervention group versus control group for behaviors and other outcomes. We also wanted to identify facilitators and barriers to engage in digital interventions, because we want to identify the social determinants of health, right? The social context around engaging in these behaviors. It's all fine and dandy to say that, hey, go walk. But what if the place that they walk is not safe enough, And using this as an excuse, really, that we want to get the data on what are the kind of social constraints, socioeconomic constraints on engaging in good behaviors. And we can do this with our study, and I'll show you how. And then finally, that deriving digital phenotypes of self-care behaviors for heart failure. Digital phenotypes for me is just a fancy word of saying profiling. Personas. We want to see the different profiles of people who engage in digital interventions for self-care behaviors. And we can do that with our data. So at this point, a lot of nerd scientists would be, yes, but where is the theory in this? What is the framework? And here it comes. So the theoretical frameworks is, so here's what, and Michi, I think, is a genius, because she developed this taxonomy for behavior change interventions, right? So think of my intervention as a recipe. It's a dish, right? And now what are the ingredients that go in the dish? And the taxonomy, like Michi's taxonomy, the BCT, like behavior change techniques, helps me tease out the ingredients that went into that recipe or the dish called sensor control digital game. So these are all the techniques that left. Yes, on the left, that you see are all the techniques that we used in what I call the ingredients of behavior change interventions that we use in our platform that were informed by this taxonomy, because they already had it. So we just we went through the taxonomy and we identified, yes, these all apply to our intervention. And then we use this, in this day and age, technology is ubiquitous, so we kind of get informed by this interdisciplinary frameworks, right? So BJ Fogg developed this persuasive technology framework. It's B is equal to MAT, which is basically behavior happens at the right motivation, right ability, and right trigger, which I think applies very well to our intervention, because at the right motivation, because the participants are willing to try out our intervention for their behaviors with the right ability, and I'll show you how, because the tricky thing that we realized in our first study with heart failure is there are people who can hit 10,000 steps a day, and then there are people who can barely get 1,000 steps a day. So how can you motivate them when people have such different goals? And that's what a flexible medium like a games can do, is it can cater to their different abilities at their level. And then with the right triggers, right? Like with the kind of quests that they have, kind of incentives to aspire for. So that's why we feel like this particular framework really fits for our intervention. So I know this is a busy slide, but I promise I have a publication on this already. And it's freely available because of NIH. But I just want to kind of give an exemplar of what this is. So this is where we do the mapping. So remember I talked to you about the ingredients, the behavior change technique ingredients, and then we use the BJ Fogg's framework. So for the ability concept from the Fogg's behavior model, we used the behavior change techniques, and then we mapped it to our game components. So how do you map that to what the game does? And so we did all this mapping of different techniques across our game, so that it's clearly, that is a theoretical kind of foundation behind why the game components kind of work the way it works. So, and this is just an example for this behavior, for the ability concept, and we have several more. But, for more details, again, these are the kind of things that I can spend an entire course talking about. So you can check it from my article. And this is what I talked about, that adaptive tailored game goal. So we have an algorithm that's running behind that's able to adapt itself based on the participants' actual ability to attain goals. So we use their historical goals to kind of adapt the next week's goal. So that way it is true to their ability, at the same time inspiring them a little bit to aim further. And all of this comes validated by the cardiologist who was on our team, that this is exactly what I want. Because it's one thing for clinicians to say it, and it's one thing to apply it and kind of to a game medium. And that's what we were trying to do with these kind of mapping. And we were able to do this with this algorithm. And this is for the engineers in the audience, and even for the nurses. So we have this is kind of the system design from my engineers on the team. They developed this backend because it's a lot, right? I mean, we are just seeing the front end, like the people are doing their behaviors and the game progresses, but what really happens in the back end? And this is an example of that, is that we get data. So we use this sensor devices called Withings. It's a French company. So the data from the Withings goes to Withings server, and then we write something called an API. That's application programming interface. Basically, API is a fancy word for just saying it's like an intermediary. It's like a language translator. So it takes the data from the Withings, dumps it on our server, and we do some processing with that Withings data from our game data, and align it with the unique ID of the participant, because I'm going to talk about privacy protection soon, and which then goes to the game. And again, this is the constant feed forward feedback. Like the game data goes to the backend and all the processing is happening in that backend server. So this is kind of the backend infrastructure that's driving our game platform. So now, remember we had this participant who was disappointed the game ended early. So obviously with more money from R01, and I would think that's more money, but it's never enough money, but just enough to make some more tweaks. We now have like multiple levels, each with its own sound system, and it's infinite levels. So the way we have done, like earlier, the game would stop at 3, but now the game would continue infinitely, like they can play. And what we do in our study is, again, something that I saw with telehealth is that people would have telehealth devices and then home health will take it back. So then by that time, patients have already got used to telehealth and now you have to wean them away, right? So what's the point of giving these devices if you're going to take it away from them? And that's exactly what we do in our studies. We don't take back our devices. We just give it. There is no point in taking these devices back from them because it's going to get outdated soon anyway, and you can't even reuse it. So then why? So we somehow managed to convince NIH that we're just going to give them the devices and they can do whatever with it after that. If they are using that to continue the behaviors, that's great. Let's let them do that. So, which is what the idea is, even if they're not part of our study, and I'll talk about the privacy thing soon, they can decouple it from our study data and they can continue to play the game, use the devices, whatever they want to do. And then we also introduce some long-term behavior quests. So not just daily quests, but something to aspire for, like over multiple levels. So they get, incentives for that. And then finally, the game avatar. So we never had an issue with the males. Okay, the male participants in our study were just fine with the avatar, but the females, it was very hard to please because if we had too young an avatar, they said we don't want our avatar to look like the People magazine models. We want it to look realistic. So we developed an older adult avatar, and they said this one looks so old. Like I don't want to look so old as this. So what we did this time is we're like, okay, you know what? You decide how old you want your avatar to look, and you decide your skin tone. So now we have like a slider where they can decide how young or old their avatar can look like and whatever the skin color. And for those who don't want to choose either male or female, we also have like a cute other character that they can choose. Then we also build for, we want them to stay in the game, make it more fun. So we are never going to let go of a slot machine, right? Because that was our bread and butter in the beginning. So we also have like a mini slot machine. But again, this came from a participant suggestion that why don't you make it more health themed? So instead of the typical slots, now we have like a health themed slot machine, some words scrambled. All of the words are based on health terms. So finally, game over. So this is just an example of game over in our study. So in this, how do you motivate the person to climb the mountain? That's with an ambulance chasing them. So if they have to avoid this ambulance, they have to climb the mountain fast. But it can easily be, adapted to anything. It can be like a Yeti chasing them up on the mountain, or it can be a monster, or it can be them falling up, whatever, It's easy. Those things are easy. As long as you have the back end built, then these kind of changes to be done are relatively easy. So, but this is what we use in our study. Apparently, the reviewers liked it, so we'll keep it. And this is what I meant. Like I said, for me, terms keep changing, but it's really the same. This is like, we want to build profiles, right? Ultimately, we have personalized it, but it's not enough. We would like to personalize it to the socioeconomic and, just the biopsychosocial status of patient. So now, in addition, we have data on the daily behaviors, the game backend. We also have data on the weather because of the wide variety of zip codes from which our participants come from. We also use EMAs, which is basically ecological momentary assessment, which we don't have it every day in the study, but intermittently, we ask them, did you engage in behaviors, yes or no, and what were the barriers and what were the facilitators to engage in behaviors? So we get that. And these, the choices are informed from, study. Like if you didn't take your medicines, could you afford it? Could you not afford it? If you could not exercise today, was it too hot, too cold? Because climate change is happening, right? Which is why now I feel like when we have this in the wild testing of these kind of interventions or behavior interventions, you cannot discount the effect of weather anymore, because Texas is going to get really hot and then it's going to get hard to walk outside. And I know like this was a record breaking year in terms of snowstorms in Buffalo, right? So it's happening. So we need that data. And then finally, upstream risk survey, where we also collect data on their risks in their lives. So this is like a baby study. We're really in the beginning days. So I'm so thrilled that you asked me to talk in these early stages with you. But we are still collecting evidence. So at this time, we have 19 participants enrolled so far. So roughly the data, we are still at 64% male, but the study is young. We have 2.5 years of data gathering left. So we hope to hit like a good balance. 79% are white, so we hope to hit a balance there too. We have most of our participants tend to be from Texas, because Texas does have a high concentration of people with heart failure, followed by Georgia, and then some from Oklahoma, Louisiana, and Alabama. We haven't got any from Arkansas and Mississippi yet, but we, again, like I said, the study is young. So this is an interesting population, because only 32% are high school educated or lower. So, the other pushback that I often get, it's like when you use online social media or kind of recruiting, you're not going to have access to a lot, right? Poor people who are not having smartphones or on, using Facebook and, the relatively well off. Well, I can, in our sample, 50% of financial difficulties. My point is, so my argument is, using that as an excuse, do we deny interventions? But why can't we train them? Like, why don't we go to our population and train them to use these devices? Like, why just deny technology? Like, I often seen that, that population is not good. They cannot use technology. So this is not a good study. And that's like, I'm not sure if that's ethical, because then you're denying a whole swath of population access to an intervention that is definitely helping, the so-called well-off or the so-called, with a higher privilege and the higher socioeconomic groups. So, and then what we are seeing in our studies is that it is, everybody is, because of smartphone and again, because of COVID, a lot more proportion of that population is online and are using this media. So we want to go there where they're already and get them and, increase access. So, but again, that's just my argument, and there are many arguments, and I acknowledge that. So again, in this turn too, you see that like 85% in my R21, and just again, it's heading towards 90%. So now we have 89% who played games before. Again, like I said, it was only 47% in 2015. So, and results of this is already published. Not results, but the preliminary studies are published here, and we're soon going to have the protocols in JMIR. So then, how am I doing with the time? Good. 5 more minutes? Oh, okay. All right. I'm almost done. So then this is the next study. So it's kind of like right away we got our next R01. And the idea is, how do you apply this concept? So this one is for cultural adaptation of our platform for hypertension self-management, which kind of overlaps with some of the self-care behaviors with heart failure, but also in a minority group like Dr. Dean Wysocki mentioned, in that group. So again, because the platform is so easily customizable, we will bring in their themes and their motives, their icons, and it won't even be about mountain. Because when I talked to the group about climbing mountain, they started chuckling like, hey, we don't have any mountains here. We have swamps and rivers. So be it. So let's transform this into crossing a river, by boat or crossing a swamp. So it's my point is like it's customizable. And then we also have our another trial happening side by side because, hey, I'm from Texas. What's not having a Spanish language version of that would be criminal, non-ethical. So we have another small funded study where we are developing a Spanish language version of the game. So the future is, based on this kind of data, we want to adapt interventions to socioeconomic context and not just disease context. And the idea is to be sensor agnostic, which means we can integrate data from any kind of sensor. And so right now we are just restricted to things, but it could be that anyone has anything, any tracker, or we can give them any tracker and we should be able to get data. Or even for heart failure, there are sensors that can track impedance or sensors that can track swelling in edema, anything, or like a wound healing sensors, anything you can. The idea is to integrate that data and bring it into a game. And then it's inclusive to patients with varying cognitive and physical abilities. Again, with heart failure, people tend to have cognitive impairment. And we found in our previous study that like 90% of them had some form of mild cognitive impairment. Despite that, they were able to engage with the intervention. So the idea is, again, make an intervention so simple, so easy to use that a wide range of population can use it. And then finally, of course, our goal is to outreach to areas with low tech access and healthcare access. The intervention that we have doesn't really require a lot of bandwidth. We work with our engineering team to make this as less not technologically needy and as less with needs for tech kind of privileges, so it can be reached. Of course, I so want to acknowledge my interdisciplinary team, without which none of this would have been possible. My partner in crime, Dr. Christine Julian, she's from the Mobile Computing Division from the Electrical and Computer Engineering in UT Austin. Thomas Baranowski is known as a father of games for health and has developed several games for children with asthma and diabetes. Matthew O'Hare is our wonderful game developer. And then Paul Rathaus and Jay Bartroff are the statistical experts in longitudinal data modeling who develop those really cool plots. James Custer is a statistical analyst, and Edison Thomas will be using machine learning for behavioral data mining and helping us develop those profiles. Our nursing research team, Dr. John Lowe, Dr. Jada Brooks, and Melissa Kelly, who would be working with us for the Native American cultural adaptation. Janice Hernandez and Yuri Gomez are helping with our Hispanic cultural adaptation. And of course, our Myung Kim, Dr. Myung Kim, who was the PI for the P30 Center and actually introduced this idea of games for health. So without whom none of this would have been possible. I also would like to acknowledge my staff and my clinical partners, and thank you.
Thank you. May I? Sure. Sorry. Thank you so much for the wonderful presentation. We have about 5 minutes for questions. Any question from the audience? Our students are passing the microphone around. Just raise your hand.
Can you hear me?
Yes.
Yeah. First of all, I'd like to acknowledge there's two type of nurses in the world: home care and those other ones. So it's nice to hear from a home care nurse. I actually worked for the Joint Commission and made home care visits.
Uh-huh.
And I saw some of it in Texas, more in California, but there, particularly with Hispanic groups, there are true illiterates
Yes. Yes.
And so I was wondering if you have plans to.
Absolutely. Great question. Yes, that's exactly what we saw in our pilot study for the Hispanic Spanish language adaptation. And we saw that. And so we are going to have an audio capability. So the idea is whatever text, and apparently it's not that hard. And so whatever text we have, it's going to read out to them. And then soon we are going to adapt that to all our interventions, English language and whatever. And that definitely came from that pilot study. Yes.
Thank you for a very interesting presentation. When you provide your content, are you repetitive in the information that
Sure.
you provide along the way? Because part of learning is repeat,
Yes.
repeat, especially for the population involved.
Absolutely. We do aim for that. So the idea is the first 3 levels or so, they get new information. And then because the levels repeat indefinitely, after that, they can choose which content they want to improve their knowledge on. So we are giving them some level of decision making, to choose which content. But yes, because the levels are infinite and the knowledge content is tailored to each level, depending on what content they choose, that particular level would repeat. Yeah, there's one here.
Hi, great presentation. My question is regarding the use of technology and having people coming from different areas in Texas and also now from other states. Do you have any challenges with making the technology available for them as far as having a smartphone or Wi-Fi, and how to incorporate that in your grant writing?
Sure. Yeah, absolutely. Yeah, we do that. So we do have funding. I mean, we ask budget. We make budget for that. We ask money for Wi-Fi access. We ask money to provide smartphones to those who don't have, because we believe these are some things that we need to put in some effort to help the ones who are not on the technology comfort, to help them make more comfortable. But yes, we do write it in our budget, and we make that justification this is needed. And NIH is all about that, is to make technology available to the underserved. So that's what we do. Yeah. And like I said, it doesn't require a lot, really. We need a little bit of Wi-Fi, and we will provide the smartphone. And our technology can be used on Android or iOS. So you don't just need an Apple. You can even on a cheap $30, $40 phone. In fact, we had a participant who was using, I forgot the name, the senior friendly phone. What's that thing called? Yeah, I forgot. Cricket or something else. It's very minimal thing, and our technology works just fine on that. So, and it uses Android platform. So yeah.
Hello.
Yeah.
Hi, I'm over here.
Yeah.
Thank you so much for the excellent presentation. So, could you speak a little bit more about the customization of the content? I work with pulmonary hypertension patients.
Great.
And is that at the level of the diagnosis, can you tailor it to each individual participant, because they might be on a different modality of medication?
We haven't gone there yet. At this point, we are erring on the side of keeping it, more pragmatic, more practical self-care tips, and not as much on pathophysiology. And we do provide a medication information, but it's not yet that tailored. Eventually, our goal is because we get the discharge summary, we have the medication list, and then we can tailor that content. But that's really the next step. My answer to that is yes, it's possible, and we are working towards that goal.
Hi.
Yeah.
I have a question from the chat from Crystal. She says, I think this is fantastic. Is there an idea of when something like this would be available to nurses like us to offer to our patients?
I didn't get the question. Sorry.
The question was, is there an idea of when something like this would be available?
Sure.
be more widely available.
Sure. Yeah, no, so here's like, this is what my senior members on my team caution me is like there's so much excitement, but they kind of keep me grounded. We still need the evidence, it's still the R01 study. We have encouraging results, but we want the evidence. So I'm waiting till we gather like such strong, irrefutable evidence and then go down the path of commercialization. The idea is to get it licensed. We have the copyright, and go down that route. But we have to curb our enthusiasm at this point and just wait to see the evidence first. There's one question there.
Hi, thank you for a great presentation. Once you're at the point where you're rolling this out for the general public, is there any kind of plan to have the programming alert the physician or the cardiologist if there was, indicators that they weren't doing well? Absolutely.
My goal is ultimately to have a prescription for behaviors. So this would lead towards that goal. Like, how do you get physicians, clinicians to prescribe behaviors, right? But I'm still waiting. The honest truth is I'm still waiting for the technology to kind of settle down. Nowadays they're talking about FHIR, I mentioned the APIs. I know these are words, but basically the interoperability between our devices and the EHRs are going to really improve, believe me or not. But it is, so I'm waiting for those kind of things to kind of stabilize, and then our goal is, and again, that's outside the scope of the current study, but maybe we can have a study exclusively looking at that kind of integration and looking at how to visualize behaviors. And so that, because even in UT Austin, we have a new med school, we have clinicians who are prescribing behaviors or apps. They actually prescribe apps. So if someone needs to improve their behavior, so we want to get there. Work in progress, not yet there. Yeah.
Okay. So how do you take care of this data privacy?
Yes. All right. I was going to get to that. We don't use our participants any information at all. So we create dummy email IDs to so that, because of all that things need, because we are using a third-party company, but we want to protect our participants. So as long as they are in our study, we use dummy email IDs. We create email IDs for them, and we connect that with a unique ID, so that way their personal information is kept completely intact.
But there is still risk of unintentional data leakage, right? So just trying to extrapolate based on different personalized symptom, you can always find out who is possibly the patient is. You might not be able to identify that exact individual, but that's unintentional leakage.
We do go through rigorous IRB approval, and we have strict protocols. The reason why we chose it is an European company, which means they have to conform to European GDPR regulations, which are very, very strict, way more stricter than US expectations from tech companies. And that's the reason why we chose them. So they have all those protections in place. And then UT server, we have VPN, we have all those kind of protections in place. So between that, we are hoping to protect them. In terms of persons identifying, we don't share the zip codes, in our publications. So, yeah.
And the second question is, when you talk about that game goes on forever, there is also a risk of getting addiction, right? That causes other set of problems like sleep deprivation.
It's a good addiction to have, because they can only play the game if they do their good self-care behaviors. And the way the game is designed is really, you only need to play it for 5 minutes or 10 minutes a day. It's not something that you can play forever, because then you got to get your steps. And there is a limit to the goal you can get in a day. So we design, obviously we don't expect older adults to sit there playing the games all day. The way the games are designed is, it's kind of like Duolingo, if you all know, it's just small chunks. You just play the game in small chunks throughout the day. And that kind of addiction we would love to have. Yeah.
I have I have another question from this is Sam. She's in the chat. How would you protect someone who say has a bad track record of good behavior for heart health from discrimination from agencies like health insurance if this would become mainstream for physicians?
Okay. Yeah. I don't know. That's a great question. And that is something that we would definitely explore in next studies. That's a good ethical kind of exploration, and I mean, I think at that case is where the privacy question would come into play, is that how do we keep it private? We just don't share it with health insurance and go from there. And then the clinician practice, what are their policies and regulation? But again, these are great questions, and we are still in the beginning, of the field. So a lot of work to be done. So ideas for everyone out here. Yeah.
Yeah. My question is kind of more on the back end stuff that's going on here when I'm thinking about the integration of the devices with your server.
Yeah.
Then, and as you pointed out, it's all the time Fitbits are changing and updating. And I'm just wondering, how much computational energy do you have to put into maintaining all of this integration of these networks across multiple device platforms and all of that? How do you handle all of that? And what's that burden like, and how much effort? Because I'm thinking, how often do you have to debug and all those kinds of things?
Yeah. So for this study scope, it's one GRA, ComScience GRA, that's research assistant, and we're using only one device precisely to avoid that kind of complication. Because, hey, face it, we are a research study. We are not a technology company, right? My main goal, this is very hard, and it took me a long time to get here, is that my goal is as a researcher to contribute to science about the feasibility and implementation, and with using one example device. But say if this balloons into become a technology company, then that would be the role of the CTO of that company, which I don't intend to be. So I am my research are firm in the my feet are firm in the research, and that's what I want to do. Is I just want to contribute to science. But those are tech company issues. Yeah. Yeah.
Great. Thank you so much. This is such a wonderful discussion. Let's give another round of applause to Dr. Radhakrishnan.
Thank you.